Okay, welcome everybody to this final episode of the iHub. iHub is a series of webinars introduced by iCare Academy, based in iCare Hospital in Alexandria, Egypt. And this is the 10th episode of this season, and it's the final episode until we go for season 2. Today, we're going to discuss the issue of managing retinopathy of prematurity, an issue that seems not yet in consensus. Not everybody worldwide is treating in the same manner, screening in the same manner. Facilities is a problem. Doctors are not available everywhere to manage, treat, diagnose these cases. I hope this would be an addition, and I'd like to welcome our faculty from Egypt and abroad. I'd like to very much welcome our dearest professor, Dr. Hany Hamza, who's not yet logged in due to some internet problems, and he is one of our professors, mentors, an older colleague based in Cairo University, and he definitely has some expertise that we'd like to share in the area of medical and surgical management of ROP. In Alexandria, we have our dearest colleague, Dr. Ahmed Abdel Hadi, again, fellow colleague at Alexandria University, assistant professor, specialized in the field, very much interested in managing ROP cases, especially recently surgical interventions, and I hope he can add a lot to this discussion. And today I'd like to leave the floor to my dearest colleague, Dr. Mostafa El Manhaly, younger collaborator, very, very keen specialist in this issue. Since day one, he was interested in managing ROP. We started together this like 12 years ago. And I think we have went along a long way in this field. I'd like to let him moderate today's session and introduce our international faculty.
I would like to introduce Dr. Susana Teixeira, consultant of ophthalmology in Portugal, and we are delighted to have her today with her invaluable scientific experience in the managing of ROP. And my dear colleague and my mentor and consultant last year, Ms. Roxane Hillier, Vitreoretinal Consultant and the lead of research in Royal Victoria Infirmary in Newcastle, United Kingdom. And we are so pleased to join us today to share your evidence-based decisions in the management of retinopathy of prematurity. And finally, my mentor and tutor, since I have been an ophthalmologist, Professor Dr. Ahmed Souka.
Thank you. No problem.
Okay. So
I guess the first issue would definitely be in the area of looking at these babies. Which babies do we look for? Where do we see them? How do we see them? How do we document it? And next sessions, management options. So I'd say which babies are to be screened?
I think first we would like to tackle the issue of the incidence of ROP in Egypt, and then we will see it worldwide. The incidence of ROP varies between different countries, and even in the same country, according to the inclusion criteria the study included. So in Egypt, we have large variation between 19.2 and up to 69.4. So, Dr. Hany, from your opinion, what is the correct or the true incidence of the disease in Egypt nowadays?
Well, I think there is increasing awareness of the disease in the past few years, especially due to many medical legal problems that were encountered in neonatal ICU units because of children getting blind. But I cannot give you an exact incidence, but I can tell you that certain areas of Egypt, they do have problems, like in northern Delta, in some of the governorates near Alexandria and others. There is still a lack of, but I mean, there is no definite figure. I don't think we have accurate statistics for this.
And Dr. Teixeira, do you have a specific incidence rate for the disease in Portuguese?
Well, thank you for inviting me. About the incidence of ROP in Portugal, we don't have a study that tells us the official incidence in Portugal. In my NICU, we have an intermediate incidence. I mean, the babies with ROP are almost 25%. But babies with ROP that have the level to treat is just 0.1%, you know. So we can screen and see in our NICU quite a lot of ROP, but to have treatment, usually 1 or 2 per year. I do the screening just in my NICU, but I treat all the babies of the south of Portugal and the islands. And well, there I have a lot of problems because there are a lot of babies to treat from other NICUs. So I usually per week treat 2 or 3 babies from other NICUs. So I think that in Portugal, the incidence of babies with ROP may be quite high, and perhaps the babies to have treatment are higher in other NICUs than mine, but we don't have official numbers. But yes, it's a problem. It's an health issue problem in Portugal.
Ms. Hillier, what about UK? I think according to the Royal College of Ophthalmology, there is an annual update about the incidence of the disease.
Yeah, I mean, the latest national survey that I'm aware of demonstrated that of babies weighing 1,500 grams or less, the incidence of ROP was about 4%. But for our population of the northeast of England, which is getting on for 1 million people, I would say we treat between 30 and 40 babies a year that actually reach the criteria for treatment. So it's pretty prevalent. It's very hard to compare that with the data you're presenting because of the different outcomes and criteria being used.
Yes. Okay, Dr. Abdel, do you feel that the incidence of advanced cases at stage 4 and 5 is decreasing with better awareness about the disease compared to 5-10 years ago, or is it increasing?
No, definitely it is decreasing a lot. I think the incidence of stage 5 specifically, since I started to treat this stage surgically, has gone down a lot from 5 years ago. I can comment accurately on Alexandria. Have a very good screening program for the university hospitals and also for the private hospitals. So most of the pediatricians now are aware of the problem. They call us to see the babies in the NICU. They send the babies to the clinics. So definitely the instance of these severe stages or surgical stages of ROP have gone down a lot in the last 5 to 6 years.
And when do you initiate fundus examination? What are the criteria to initiate it?
In Egypt, we don't have a published criteria, but we usually attain the British or sometimes the Indian, which is below 34 weeks. If they come below 34 weeks, if they come below 1,500 grams, and if they come above 34 or 35 weeks, and above 1,500 grams, but they have an unstable course in the NICU, they have stayed a lot, received blood transfusion, have a lot of comorbidities. The babies which the pediatrician or the NICU specialists are specifically worried about. We usually follow the hunch, and we usually get ROP in babies who are born at 38 weeks or something, if they have a very unstable course and they have stayed in the NICU for a while. Just today in my clinic, I saw a baby who was born at 38 weeks, and there is an evidence of regressed ROP in both of his eyes. He came, of course, after 6 months, but there is an evidence of regressed ROP. So the baby ROP, this is a specific problem in Egypt or in India or in the countries where we get a lot of premature births.
Yeah. Do we have an age that we can say to everybody, you do not need to screen this baby because it's already this old, or in other words, also birth weight? Because, you know, age or gestational age can be fallacious. I mean, if we calculate a baby of 38 weeks, it might be 35. It's depending on, you know, menstrual period, last menstrual period, and stuff like that. So maybe age is a bit difficult to say exactly, but birth weight is a definite thing. How heavy was the baby is something concrete. So do you have a weight that above it do not screen these babies? I'd go for Dr. Hany first.
I don't think, I mean, this is applicable in any way, because the etiology of this disease is multifactorial. I mean, although we know that birth weight is very important and gestational age, but the general condition of the baby, the oxygenation, I mean, the oxygen settings that were used in the NICU are also important. Neonatal septicemia, intraventricular hemorrhage, other systemic disorders. So you can never feel safe, even if the baby has, I mean, a good birth weight, which we consider, or even a gestational age. And we have all seen ROPs in babies that are over 35 or 36 weeks, and they had a very bad general condition. So you can never feel safe with this disease.
Dr. Susana, how do you see this issue?
Well, birth weight is very important in the screening of ROP, but in my experience, I never had any kind of ROP that needed treatment with babies with birth weight more than 1,500 grams. So we usually don't screen babies over that birth weight or over 32 weeks unless the neonatologists ask us, or because they have some kind of problem, or because they had surgery and they had a lot of oxygen delivery during a few days. So for rule, we don't do it. But if they ask us to screen babies with heavier and other gestational age, we do. But I never, in my experience, saw any kind of ROP that needed treatment above all that weight and gestational age of 32 weeks, post-menstrual age. That's our experience.
I agree totally with the birth weight above 1,500.
But I know that in Mexico, you have, and in India, you have very severe ROP with 2 kilograms and 2 under 5 kilograms baby. So in Portugal, we don't have that problem. But in other places in the world, in Mexico and Ukraine, for instance, you have this problem. So you screen older and heavier babies.
Ms. Roxane, as a statement, can we say that at the birth weight of 1,500 grams, you have to screen this baby? Above that, it's neonatologist's discretion to send the baby. Did you see this statement as true?
Yes, I think it's true. I mean, my experience echoes Susana's in the sense that the UK guidance, 1,500 grams, less than 32 weeks. I have not seen a baby out with that criteria with ROP. And what's really interesting with this discussion is that clearly the criteria that you use is dependent on the neonatal care in your environment. So the standard of neonatal care that I'm accustomed to in the UK means that I don't see babies outside this criteria with ROP. In fact, we're even thinking perhaps we should actually relax our guidance a little bit, perhaps see the first screen a little bit later, because we just don't see ROP at the larger, older end of this spectrum, in my experience.
Okay. Do you agree, Dr. Abdel Hadi? Do you see that above 1500 is neonatologist discretion, or would you like to put a factor that if it happens, we have to screen?
Use only the birth weight. This is true. If you lose the whole situation of the child, if this child is above 32 weeks, 33 weeks, 33 weeker, and he's above 1,500 grams, I will not recommend examination, except if he stayed in the NICU for a while or the neonatologist is worried. If you take the birth only as a factor, but if you put the whole factors together, you have to consider the age with this weight. You have to consider the comorbidities of the child. If I find a lot of comorbidities, heart problems, receive the surfactant, a lot of comorbidities, risk factors, then I can examine a child above 1,500 grams. But it is in the guidelines. If the NICU doctor asks you to screen this child.
Okay, so in other words, when you have a screening program, you have to put, some criteria. So I guess that we have to depend on the gestational age and weight. All other criteria are a little bit, discretion of whoever is treating the baby, knows that he's received too much oxygen. He knows that there are too many systemic factors. But to put solid criteria for screening, I think the weight and gestational age are the only two solid things to base your screening program. Mustafa, I'd like to add something.
Yes, I would like to ask if the weight gain, the postnatal weekly weight gain, would differ in choosing which baby to follow up closely or not. And this question is about the WinROP protocol, because they said that it has a high sensitivity in selecting which baby is going to develop stage 3, and this will avoid unnecessary examination for babies that are not going to develop ROP or high stages of ROP. So did anyone account for the postnatal weekly weight gain and the insulin growth factor, or it is just a Swedish protocol that nobody followed?
Well, in Portugal, we are in connection with Mexico and with Brazil, and my friends in Brazil, they did a very nice work using WinROP as a criteria for screening the babies. And they found out that it doesn't fit Brazilian, it doesn't fit Mexico. So I was not very excited to put the babies in the platform of WinROP. So I don't use the criteria of WinROP. I think it's very usable, very fit the Northern Europe, but the South Europe, I've got some doubts, although I never used WinROP really formally in my NICU. Of course, the babies that are with lower birth, gaining lower weight and have problems about having gain of weight, they really are in risk. They are more tiny babies and more fragile babies. So it's not because of the gaining the weight that I see them most closely, but sometimes they are the babies that have the most worst ROP. But we don't use the WinROP as a criteria for follow-up in Portugal.
Ms. Hillier?
I would say that I've definitely taken on board the findings of WinROP, but not formally implemented them. But I bear that in mind. I suppose a bit like Susana says, if globally the child is not doing well and growing, then I'm aware that that child is likely to have a higher chance of problems. So it doesn't formally affect my screening protocol, but it's something I'm aware of.
Yes, and you think about them. You don't forget that one. You know.
I see in 1 week instead of 2.
So, yes, that worries you, and if they forget to ask you to see them in the next week, you remember him.
Exactly.
So it worries you a little more, but formally, I don't have studies. But in Brazil and Mexico, it didn't work.
Dr. Hany, do you take it in your consideration, or you just follow up?
Definitely, it's a very important study. I mean, the win for the weight gain ROP. But the problem is that it depends on the neonatologist. I mean, he should be very much aware of it, more than me as ophthalmologist to report this. You know how the current situation is in the NICUs. The neonatologists don't look at this point at all, and they don't even report it when they refer a patient. But it's a very important criterion. It was a very well-designed study, and I think it should be put into consideration.
Okay. Dr. Abdel, what do you use for pupillary dilatation, and for how many times? Because in the Egyptian market, we still suffer from the
lack of active mydriatics. I import them just till recently. I imported this eye drops from abroad because I have a lot of dilatations to do in my clinic. But the classical way is to use 0.5% tropicamide and 1% or even up to 2% phenylephrine if you have it. So I try to stick to these concentrations. I don't like the cycloplegico or the because of the fever and respiratory problems. So I try to stick to tropicamide, midriasil, 0.5%, half the concentration of the bottle, which is 1% in the Egyptian market, and 2% phenylephrine, which I usually prepare. I have it prepared.
Dr. Hany, I know recently they have introduced a new mydriatic eye drop for pediatric age group. Is that correct?
Yes, it's the 2.5% phenylephrine single dose unit. It's now available in the Egyptian market.
What is its name?
I can't recall the name, but actually I have it in my clinic.
Okay, so maybe I will call you.
I'll send it to you later, but I got them. It's a single dose unit, preservative-free, and 2.5% phenylephrine. They also made the tropicamide, but in a 1% concentration as well.
And Ms. Hillier, what do you use?
Yes, tropicamide 0.5% and phenylephrine 2.5%, 2 drops 15 to 30 minutes apart. And I must say I haven't run into problems with it, you know, and it gives me a good 2 hours of mydriasis. So I must say I use it without too much caution. Thankfully, it's available to me.
Okay. I had a case of paralytic ileus and abdominal distension one day after examination with cyclopentolate. Did anyone encounter such a complication? And the baby was readmitted again to the NICU for 3 days. Do you usually get any of these rare complications?
No.
I got once a respiratory arrest in my clinic from cyclopentolate.
Well, with cyclopentolate, in my experience, they had more bradycardia during the time they had dilation. And sometimes they not stopped, but when we were observing them, they had very hard bradycardia. So I changed from cyclopentolate to tropicamide. So I never had that problem. But yes, some babies are very sensitive. I don't know if it's just to phenylephrine or to tropicamide, but some are quite sensitive, but never had any severe problem with phenylephrine 2.5% and tropicamide 0.5%. So never used, no more cyclopentolate.
Okay. So by now, according to the ETROP, type 1 is clearly identified and it should be treated immediately. But still there is like uncertainty about the method of treatment, whether laser or anti-VEGF. So Dr. Souka, How would you grade this image and how would you proceed? Dr. Souka?
Souka, unmute, please.
Yeah, without going into, too many details of evaluating and areas and stuff like that, when I see actually this photo and I see this prominent elevation and the new vessels, to me, it's full of new vessels, too many clock hours for me not to treat. So without, trying to evaluate it too scientifically, this photo for me is for treatment. I do not leave such condition, especially when I'm treating with anti-VEGF. Previously, when we tried with laser only in the first year, like in 2009 or 2008, I felt it's very difficult to treat these patients and the babies. It's too tough to put the laser, and wait for some regression. Once we had the anti-VEGF low doses of Avastin with what to me is a magical response in ROP, whenever I see too many new vessels in 2 or 3 clock hours, I inject. And I definitely had very nice responses and good long-term outcomes in such conditions.
And what do you prefer for
stage 3? I inject low doses of Avastin mainly. Very rarely we tried Lucentis. I haven't tried aflibercept. I still feel Avastin is bevacizumab is very reliable, reproducible. We are studying together, the Lucentis effect, and it does seem to be a little bit less than bevacizumab, but definitely effective. So I rely on the well-known bevacizumab response, low dosage in the area of, let's say, 0.08, I guess.
Oh, 0.625 milligram, yeah.
Yeah, in this area.
Ms. Hillier, how do you proceed?
Yeah, I agree. We can't see the disc very well, but it looks like the vessels are very dilated and engorged in stage 3 at the junction of, zone 1. Definitely for treatment, and definitely by my personal protocol, this would be a baby who would receive Avastin within 24 hours of looking at this. So the standard dose we've been using for the last sort of 6 years is a 0.16 milligrams of bevacizumab in 0.025 ml. And I think this would start to settle down very nicely within 48 hours of that dose. And we probably have about an 80% chance that that's the only treatment that this eye would need, even in this fairly aggressive disease with what's probably got quite nasty plus. So this would be an Avastin eye for me. Yeah.
Okay, and there is no problem to use it as an off-label drug, right?
No, I mean, until very recently, there was no licensed drug. Only 2019, the EU approved Lucentis, which I don't yet use because, as Dr. Souka said, my experience is I have had, it was like magic. It's just wonderful and reliable. Yes. I trust it now. I know what to expect. And so I have no reason or evidence that convinces me to move away to ranibizumab at this stage.
Mm-hmm. Okay. Dr. Abdel Hadi, I know you use nowadays aflibercept, right?
First of all, this case, it's a stage 3 junction between zone 2 and zone 1. We cannot see the disc quite well. To be in the criteria of pre-threshold type 1, you have to have a plus. But of course, a very important factor is the level of activity of the stage 3. This is an active stage 3. You have dilated tortuous vessels that reaching with abnormal configuration. So I don't care so much of defining whether it is a pre-plus or plus if I cannot make up my mind. This is a guy for treatment, a baby for treatment, especially if he's in the window of activity of the RP between 34 and 38 weeks post-menstrual age. As for the treatment, what type of treatment I would choose, until recently, the evidence base is to use only anti-VEGF in zone 1, according to the BTROP study. But since the appearance of the Rainbow study, which compared ranibizumab 0.1 and 0.2 and laser treatment, and the very good results of 0.2 milligrams ranibizumab compared to laser, I've been using ranibizumab or aflibercept because of the multitudes of papers or of work on aflibercept. both of them work quite well in my hand. I use 50% of the adult dose. I use ultra small dose, which is 25% of the adult dose, if I'm re-injecting in acute recurrence. As for the difference between the ranibizumab and the aflibercept, I've stopped using bevacizumab because of the factor in Egypt of the vision and of the stuff like this. So I've been using only for as for the efficacy, I think both are very effective, but aflibercept has a special post-injection criteria that I've yet to publish, that the effect of the injection is slightly slower than we used to see in the after the Avastin injection. Avastin injection, like we all agree, it has the work of magic. But the aflibercept, it's a slower response of the child, but a very long-lasting and a more physiological effect of the injection. So I'm mostly injecting aflibercept or ranibizumab according to the situation and according to the hospital situation. This is an injection child for me, and I inject 50% of the adult dose, either ranibizumab or aflibercept.
Dr. Hany, your preference?
Yes. First of all, sorry, I cannot see the image, so I will be logging in from another computer shortly. But I have been listening to the discussion. What I've been using is ranibizumab over the past maybe 6 or 7 years, simply for one reason. I mean, pardon me, Ahmed?
No, fine, sorry.
Okay. Can you hear me?
Yes, we can hear quite well.
Yeah. Okay. I've been using ranibizumab, first of all, because it's safe, because I'm injecting bilaterally in a neonate and simultaneously. So this is an additional risk by itself. I have been using bevacizumab before, and it was very effective. I cannot deny that. But because of fears of preparation of the drug and being off-label, I decided to switch to ranibizumab. The difference I noticed with ranibizumab is as follows. First of all, it works very rapidly. It's very effective, but it has a longer lasting effect, and it leads to a slower development of the retinal vessels to the periphery. So if the vessels were to reach zone 3 in 1.5 months with bevacizumab, no, it can take up to 3 to 4 months with ranibizumab. But I'm using Lucentis or ranibizumab in these cases. I have no experience with aflibercept now.
Okay. Dr. Susana?
Well, from the image I see here, I see it's posterior zone 2, stage 3 ROP. And from what I see inferiorly, it has a brush border, at least, or a vitreous hemorrhage, but I don't know because it may be the quality of the image I see. So, of course, it's a posterior ROP, and I think the indication for anti-VEGF therapy is obvious. I would just be very careful in the follow-up of this baby, because if it is a brush border or a vitreous hemorrhage, we can have a attractional retinal detachment. I don't know if you can see it here. So I would inject, but I would be very careful, and I would be sure that would have an OR where I could go, and if you have a retinal detachment, you should make the surgery. So I would inject, but would be very careful with this baby. I've been using bevacizumab for 14 years. And as our colleague, I really rely on it. I know how the eyes answer. I know how it will regress. So we know all about this drug, and still don't know completely how does it work with Lucentis, but for sure it will work the same. The problem will be the time the drug will stay in the eye. So you can have recurrences, as we all know. 50% of recurrences is a high number when we do have just 8 to 9% of relapse disease after the injections with bevacizumab. So you must think quite well about using a new drug, even if it is on label. But I think that focusing in this eye, I would really use anti-VEGF. In my case, I would use bevacizumab, but would be very careful looking at that inferior border of the inferior temporal inferior retina. But really, anti-VEGF and bevacizumab, it's a very good drug, very reliable, if it is used in the correct indications. So if it is used in the correct indications, you can have, like everybody has, disappearance of the ROP and the growth of the vessels along the retina, normal vessels along the retina. So we have other drugs now in the market, but still not as long experience as I do have or everybody has with bevacizumab. I still go on with the 0.0 cc of bevacizumab, not lower than this, because in my cases, I think the ideal would be to titrate the VEGF and inject according to the level of VEGF inside the eye. That was the ideal world. As we don't have, I'd like to have the minimum dose that I know that will have no much relapse diseases. So 0.02 cc's of bevacizumab in my hands has 8% of recrudescence relapse diseases. So focusing again in this image, I would take care about the temporal inferior arcade and this brush border or vitreous hemorrhage. I cannot say really how it is.
Yes, there was no vitreous hemorrhage, and this baby was injected, 0.625 milligram bevacizumab, and was good peripheral vascularization by the end of the 3rd month, as Dr. Hany has said, yes.
I have an important point to ask here. I think nobody is suggesting that we, for example, give laser to such cases, right?
No, for sure, no.
So,
no.
I mean, do you have any case, whatever it is, in whatever stage in ROP, that you'd consider laser as your first option with anti-VEGF available at hand? I don't.
Yes.
Well, Well, I began a long 20 years ago, so I'm used to do laser. When I mean, zone 2,
it's better for laser.
Zone 2, through stage 3, zone 2, middle zone 2, where I know that I'm not going to induce myopia, and really I want to induce myopia if I do 800 spots. So sometimes in these cases, it's my first choice. So I do it and say to the baby, go to your NICU, and I will not have any kind of problems. So really, in this case, zone 2, intermediate zone 2, stage 3, I do laser. Yeah, and I do a lot of investing, but still do laser in those cases as first instance.
Why? Why is it better to do laser in such case?
So because I treat babies from other hospitals, and in these cases, I never had any kind of relapse disease. So really, I don't have to see them again, so I can send them to their ophthalmologist without having the problem if I have some kind of relapse disease, if I have some kind of problem. So those cases I treat and go.
But according to the recent Rainbow study, in the arm of the laser, it was 3 arms. Every arm was around 70 patients. Recurrence was about 10 patients in every arm. So there was still recurrences seen in the laser groups. So if it is done just to get rid of long follow-up or insufficient healthcare providers, I think the laser will do its complications as myopia, cataract, whatever.
No. I'm saying stage 2, but very.
But the issue, Mostafa, is when is the recurrence with the laser and when is the recurrence with the injection. You can have a child where you inject the child, like Susana said, the child comes to me from another country and I tell him I will inject the child, but I have to follow him up for a while. I can't tell the parents that you are safe for a long time before, and the parents have to go in a week or 2. I would be more safe with proper laser placed and following up the child for 1 or 2 or 3 weeks, then with injection and following up the child for 3 weeks, because usually the average time of recurrence after the injection is around 14 to 17 weeks. But the laser is once you see it gets effect in place, it is there. So it's
yes.
This is a real situation.
Does it worth to sacrifice the periphery of the retina just to minimize the follow-up period?
I think the issue about follow-up and late recurrence is an important one. I think I'm a great fan of laser. I would say I do about 50% Avastin, 50% laser. It's partly the follow-up issue, because you have to, as far as I'm concerned, post-Avastin, really, you have to follow them every 2 weeks till they're in zone 3. And sometimes you will just lose these babies if they live a couple hundred miles away. That would be devastating. But the other thing is, there is this very real concern. I'm becoming less concerned the lower the dose I use of the systemic side effects. And I really trust laser. I feel like laser applied confidently and confluently in the right babies has a virtually 0 recurrence rate. So again, I really trust my laser. It allows me to discharge the baby safely.
Yes, that's what I say. So in peripheral zone 2, I never had a recurrent disease in laser. But in middle and peripheral zone 2. So I never had. I do confluently. I do good laser. So I began to do laser in my life. So I do confluent. I'm sure about all I do. So in very peripheral and intermediates, I don't induce. So it's an area of laser that does not induce myopia, because if it's induced myopia, so in posterior zone 2, I don't do laser. But peripheral zone 2, stage 3, I safely do laser without inducing any kind of myopia. So that's the case. And elements either, there was not in a study, HOPE ROP, there was no difference, or it was even better the laser, but there was no difference between laser and Avastin. Remember the study. So in very peripheral cases, I safely do laser.
I have a personal opinion in this area. That, of course, laser is well studied for years and years, so we feel safe because we know what happens like in 5 years, in 10 years, in 15 even years. So we feel we know how this is going. But until we get like 20 years follow-up of anti-VEGF, we'll always have these fears that maybe the incomplete vascularization can cause something. So we feel unsure because of the difference in the duration of studying the management option. I think in 10 years' time, I don't think anybody will be laser, in my opinion, personal opinion.
Dr. Hany.
I hope.
If I may just add that I've been treating since 2007 with anti-VEGFs, these cases. And I think anti-VEGFs are really superior to laser in these cases. You don't lose the peripheral field. You don't induce myopia or astigmatism or weakness of the sclera. And I think this is my primary choice of treatment. I had to do laser in maybe 2 or 3 babies with recurrences in zone 3. After that, on follow-up. I think it deserves that we insist on follow-up on these babies rather than doing the laser. And as Ahmed just said, in a few years, maybe laser would be obsolete in ROP.
Okay, this is another case. Dr. Susana, can you comment on how to treat?
Sorry, this case?
This is another case with less, with less severe.
Yes, it's a someone ROP. Not completely aggressive posterior ROP, but you have flat neovasels on the temporal superior arcade, but it's a zone 1 ROP, so I would treat with Avastin for sure. You can see the flat, I think it's flat neovasels on the temporal superior arcade. Inferiorly, it's difficult to see, but with this plus disease and these flat neovasels, I would do anti-VEGF.
Okay, Ms. Hillier, you inject or laser?
Oh, for sure, this if this baby's needing treatment, it would be Avastin. If I saw this baby, would I treat them today? I think it probably depends on the trajectory that led to the development of this. I may give it 1 more week, but I would bring the Avastin with me next week. It looks very likely that a baby with an eye like this will need treatment within the next couple of weeks. Yeah.
Why you should wait 1 more week?
I mean,
the age of the child.
Sorry.
If you see this patient at 32 weeks post-menstrual age, would you inject this child?
I would not expect 1 week.
Really?
You would not wait for 1 week. You would inject him immediately.
Yes.
Even at 32 weeks.
But
Okay, well,
I
discuss the time of injection, but you are to inject immediately, Dr. Abdel, right?
But I understand the point of view. I mean, it's not an aggressive posterior ROP. So more than just have the picture, you must know how it flows in time. You must know the timeline. I understand it. So it's not a posterior ROP, so you cannot rush making, but it's important, of course, to know the timeline of the disease. But I think those on the superior arcade, I think it's retinal vessels. At least to me, it seems like it. But of course, to know the timeline, to know if it was really to go into bed, getting worse, I would expect 2-3 days. I wouldn't expect 1 week, so it was more comfortable. If I didn't inject the same day, I would see 2 days later, because in 48 hours, 24 hours, you can see how it will work and what's the timeline for this eye. But I understand it would be comfortable perhaps to see how it works. But looking at temporal superior, I would inject.
I think that if we were discussing lasering this patient or not,
no,
many of us
for injection.
Many of us, if we had the laser option only, many of us would favor waiting because we don't like putting the laser in these retina.
This is not the issue to Souka. If you have this child,
I want to mention a point. I have a point I'm going for. But because we injected a few patients cautiously at first, and then we saw a magical vascularization of the periphery that we didn't really expect it to happen in this manner, we feel comfortable injecting such patients, and we actually expect that this vessel deficient retina in the periphery will look better in a month's time and in 2 months' time. So it's giving us more and more confidence to inject these patients, unlike laser that was totally not looking nice when we do it. So I feel there is a big difference in the 2 management options.
The issue I'm talking about here, if you have a 26-weeker or a 27-weeker, and he gets and you see the child at 31 weeks, and you get this picture, the level of the VEGF in the eye has not yet increased in the period of 33 weeks, 34 weeks. Would you give an anti-VEGF injection at 31 weeks with this picture, or would you wait for another week or a week and a half, and of course seeing the child after 3 days? This is my question to Roxane. Dr. Roxane, do you care about the post-menstrual age of the child and the expected level or the theoretical level of increase of the VEGF in the eye? Because usually when I see a child at 30 weeks or 31 weeks and he's like this picture, and he's at 26 weeks, so I saw him 4 weeks postnatal, or I usually wait for 1 or 1.5 weeks until I am at the 32 or 33 weeks to inject. Of course, seeing him every 3 days, so that if the condition worsens, like Dr. Susana said, I would inject immediately. But I'm not very comfortable of giving an injection at 30 weeks or 31 weeks post-menstrual age. What do you think about this?
I don't conceptually have a problem with it. I just have never had to treat at that stage. It's always a couple of weeks later that it crescendos. To me, that first visit is you're assessing the lay of the land and you're spotting this is one that's probably going to go. So I joke, I bring the Avastin with me next week, because probably the baby will need treatment. But my gut feeling is that if I saw this baby at 31 weeks, no, I don't think I would inject, but I'm expecting problems ahead of me, and I'll watch very carefully.
You'd wait 1 week to treat.
I think I would, and I would expect treatment, but a week or two down the line. But
you will definitely inject at the end. You will definitely have an injection at the end.
Almost certainly, yeah.
Sure.
Okay, this baby was injected 0.25 milligram ranibizumab, and it showed good peripheral vascularization by the end of the 5th month. Okay, Dr. Susana, could you please comment on this fundus image?
Whoa. Well, that's a stage 3 already, with condensation of the vitreous over the ridge in posterior zone 2, with very bad criteria for evolution for bad anatomical result. I mean, it has vitreous hemorrhage, and it has the condensation of vitreous over the ridge. I see also hemorrhage near the ridge on the temporal side. So, well, it's of course now to, I think still I don't have a good quality if it seems that it have elevation of the ridge, but it's an eye that can have a progression to retinal detachment even if we treat with whatever we treat. If you inject VEGF, anti-VEGF, you should have an OR.
And is it plus or pre-plus? Is the venous dilatation and arterial tortuosity, is it sufficient to say this is a plus disease?
I just see the venous, I don't see the arteries. So
is it pre-plus?
Well, even if it is pre-plus, it has a lot of hemorrhages that
okay,
we can see.
I mean, do you treat stage 3 zone 2 without plus?
Mm-hmm. But I think it is enough criterion to have this. Well, you have, of course, there is always a problem if it is pre-plus or if it is plus, of course. And you don't have enough tortuosity of the arteries to say it's a plus disease. But you have a huge engorgement of the vessels, and you have a huge stage 3, and you have the vitreous hemorrhage. So you have a lot of signs of probability to have a bad anatomical ending workup. So if it is pre-plus or plus, the only thing that we can think about pre-plus or plus is that if it was not an ROP, and definitely it is an ROP, so we can see the ridge and the proliferation. So, and from what I see, you have an elevation, very elevation of the ridge, and you have the condensation of the vitreous on the ridge. So even if you treat, I think we'll have a surgical problem for sure. If you wait, I think it will even worse if you don't treat.
So the criteria of the ETROP study regarding that stage 2, stage 3, I mean zone 2.
That's stage 3.
Yeah, this is stage 3, zone 2. I mean
stage 3, zone 2, and you have hemorrhages of the ridge, and you have hemorrhages of the vitreous.
Hemorrhage, yeah.
Yes, I mean without plus, do you treat this or not? Even if it is less severe than this without the pre-retinal hemorrhage? If you have this elevated ridge, stage 3, zone 2, without plus, do you treat or observe?
I think the difference between, sorry, yeah. I think the distinction between plus and pre-plus is a very, very difficult one to make. The difference between normal and plus. So if it's normal vessels, then one could argue not for treatment. But as far as I'm concerned, pre-plus, plus, whatever. If it's got stage 3 posterior zone 2, you're going to treat.
Yes.
And well, this is a RADCAM image, isn't it? If you push too much
might be a zone 3
on the eye, you can change everything. I mean,
the engorgement of the vessels.
It's not adequate, this pre-plus to the vascularization on the periphery. So I would guide in this image, I would be guided by this huge proliferation stage 3 and vitreous hemorrhage. More than just because you have engorgement, you just don't have you have tortuosity, but not that much. But I agree. I would treat this eye and would be ready to make a surgery, because I think it will be a surgical one.
Okay, and do you take your, if this image was sent to you by one of your fellows, do you take your decision on the image, or do you have to?
No, I would say that I would see the baby always. That's what I told you. If you
make,
so I would see always the baby.
Yes, you make your judgment using the indirect ophthalmoscope, right?
Yes, always.
Okay. Dr. Hany, do you treat this baby?
Definitely, I would treat this baby, and I would inject him. And I think he would go in one of two ways. I mean, either the surgical way if the traction increases, but exceptionally, I have seen some of these babies in which complete regression occurs over a period of weeks, and sometimes even this ridge that we see detaches and floats in the vitreous as a capacity if complete regression occurs. So, I mean, whether it's a pre-plus or plus, I would go for treatment. And as Susana said, whatever you do, laser or anti-VEGFs, both carry the risk of surgical intervention later.
Okay, I waited 1 week, and then the baby was injected, and this is the image after 6 months of follow-up with still incomplete peripheral vascularization. There's more than 2 disc diameters of avascular retina.
What dose did you have?
0.25 milligram of ranibizumab.
Perhaps those hemorrhages are not linked with the activity of the disease, but with some thrombocytopenia of the babies. And they were not linked with the activity of the disease, but with the state of the baby. If he had to have some kind of manipulations of the air, some kind of manipulation in the air throat, and sometimes they bleed not because of ROP, but because of the thrombocytopenia. But yes, it's a very good result. And sometimes, like Dr. Hany told, those membranes can detach and float in the vitreous. So very nice outcome.
Yes.
But you should be prepared for retinal surgical if you do in this case.
Okay.
Even in surgery, they do better. I mean, when you inject and then you get, some fibrotic traction at this part, and you go for surgery and just release this traction, the outcome is much nicer than, following the patient. Then he gets a little bit of traction with the aggressive new vessels, and then you try to think of surgery. It's very bad.
Yes.
So inject, and if it tracks, we'll release it. It's much, much easier.
Yes, I agree completely.
Okay, Dr. Abdel, do you have a case to present?
Yes, I have actually 3 presentations. The first is a medical presentation.
Let's make the medical one now, and the surgical aspect will be by the end of the presentation.
Mahmoud should share my screen. Okay, Mahmoud? Can everybody see my presentation?
Yes.
Okay. put the title of ROP, how long we should wait and what to do. Because this is a question we usually get who treat ROP a lot in this gray zones. Should I wait? Should I go for treatment? And what to do? So I'm going to present this 3 cases, and I'm going to ask our expert panel what we should do in this case. First case is an aggressive posterior ROP, zone 2 disease, OU, gestational age 29 weeks, postmenstrual age 33 weeks, plus sign, male with no other comorbidities. And this is a pre-picture. He gets this flat neovascularization at zone 1 with hemorrhages and plus sign, obvious. We will not repeat our discussion. This is a case for injection. So the child was injected, and post-injection 2 weeks later, we get this good result. The vessels has straightened, and the hemorrhages has gone, and this is the right and the left eye. Now, this is 4 weeks post-injection, better outcome, and after 30 weeks, still avascular peripheral area, and this is line to demarcate that we have the whole zone 3, or if I say part of those 2, still avascular, and this is the left eye. So my question to Dr. Roxane, if you have this child and you follow the child for about 3 months, 4 months after injection, and you have this large avascular zone, what's your protocol of what's your treatment guidelines, or what do you do for this child with a large avascular area and 4 or 5 months post injection?
Yeah, it's controversial because we don't, in our unit, we don't routinely angiogram babies at a certain point further down the line. And I must admit, unless I have concerns about the baby returning to the clinic, I wouldn't intervene, because we don't really let go of these babies for years. In fact, we reduce the frequency, but we keep in touch with these babies. Now, I know that you'll have physicians in the States or in Canada who I've spoken to who will routinely laser babies at X number of weeks post-gestational age routinely. They will not tolerate peripheral avascular retinas. The thing is, in premature babies, you often end up with permanent avascular peripheral retina, maybe quite not to this degree. I don't know. I guess we will learn what the implications of not lasering this peripheral avascular area are. As you say, when these babies grow up, when they're 20 or 30, will they develop retinal detachments at the interface? I don't know. At the moment, I'm not treating them unless there's a recurrence of disease.
This is a study, incomplete retinal vascularization after ranibizumab treated with retinopathy prematurity, and they found that in some eyes, the fluorescein angiography performed at 149 weeks of age showed persistent avascularity of the temporal peripheral retina. And of course, like Dr. Roxane said, it is still a debatable issue. In the United States, they laser these children. In India, they follow them up. Myself, I'm dividing these babies into 2 groups, and I'm following up both groups, and I'm seeing what we should do later according to evidence-based study. This is the first case. The second case is a female premature child, gestational age 30 weeks, postmenstrual age 38 weeks, good pupil dilatation plus sign, stage 3, zone 2. We have discussed this a bit. This is the child. We have a stage 2 and a stage 3 in some parts. Plus sign is obvious. This is back at a time where the rainbow study hasn't come out, and I used to perform treatment in the form of laser for these children. So I lasered this child. This is back in 2016, and a lot of confluent burns. I used to perform laser even on the ridge itself of the stage 2 or the stage 3. This took about 1,300 shots, power between 240 milliwatts. And this is 2 days only after laser with gray laser shots in a confluent pattern. And same eye, 9 weeks after laser treatment, showing favorable outcome. But the laser is very confluent, and nowadays I don't do this much confluent laser except for pre-threshold, for threshold ROP. and this is the eye. My question is about this foveal straightening or the vessel straightening. Dr. Hany, does it matter to you when you see this foveal straightening or the vessel straightening after laser or even after injection? Are you skeptical about later on the astigmatism or the myopia or even the visual acuity of this child? Of course, we don't have a lot of OCT, handheld OCT guided studies to show us the shape of this fovea. But actually, when the children grow up, I see these children to be they don't attain a 6/6 vision even if they are not very high myopes. What do you think about this vessel straightening or the slight macular distortion by the laser or by the injection in these stages?
Susana, I can go ahead because
okay, I can't see the entire panel, so I don't have my. So yeah. Mostafa, do you have any comments on this vessel straightening? You see a lot of ROP babies after laser, after injection.
Actually, I don't feel that it's of significance in the recurrence of the disease or the progression of the disease after treatment, whether with laser or anti-VEGF treatment.
The final visual acuity, the final corrected visual acuity when the child grows up. Do you think this vessel straightening or the slight macular dragging will have an effect on the final perfect vision of the child?
I think this is an OCT, and from the literature review, yes, they found that maybe treated with laser therapy for ROP, they have thinner fovea, and with this straightening of the vessels, they have more myopia and less visual acuity compared to those treated with anti-VEGF. So I don't know if it is the laser is the cause or if it is the severity of the initial stage of the disease that lead to this straightening and thinning of the vessels.
And of the fovea. Okay. Effect of anti-VEGF treatment on retinal prematurity in zone 2, stage 3. This is what we're discussing, that nowadays in this zone, stage 3, even with no actual plus in this study, they injected or they lasered the children according to their age. If they were very young age, they treated because as Dr. Roxane said, the differentiation between the pre-plus and plus is not always an easy one. The case 3 is a male, 28 weeks, incubated for 2 months, 1,200 grams birth weight, presented with stage 3, zone 2 with plus, post-menstrual age of 37 weeks, incision intravitreal aflibercept was given. With follow-up, slow improvement during the first week. As I've said, the aflibercept causes slow improvement of the signs. Then the child was readmitted to the NICU with pneumonia for 6 weeks, and he was lost to my follow-up. I couldn't see the child, and he was critically ill. When the child came back for follow-up, when he got out of the NICU, we found this recurrence of the disease was, as we can say, abnormal vasculature with this ridge and with this tractional ridge causing what we can say a sort of starting stage 4 or even stage 3. This is a recurrence. So the child was severely ill. I tended to follow him up for another week. After another 2 weeks, he got this. As you can see, this is a stage 4 disease. As you can see, a slight tractional detachment above, before and after this traction bridge. My question to Dr. Susana: how do you treat this child? Recurrence after aflibercept injection, starting stage 4 with this prominent ridge in zone 3.
Well, that's not zone 3. That's the recurrence on the first line of the disease. So you have vessels after. So I see this fibrotic ridge, for sure, stage 4, and you have again vessels after that. So it's a recurrence at the anterior seat of the disease and at the nuance seat of the disease, but you have already a retinal detachment. So you may try to inject anti-VEGF, but with this thickness of the ridge and this thickness of the fibrotic tissue, and already with a retinal detachment, I believe it will be a surgical matter, so a surgical vitrectomy. In this case, I would inject, but prepare the surgery. Usually I inject 2-3 days. I make surgery 2-3 days after the injection of anti-VEGF. You also could try to make a hard laser of the periphery, wait for this fibrosis to grow a little more and see if it would go on with this detachment or not, and then postpone a little bit the surgery. But I think it's always a surgical subject in this case.
Why would you inject this case? Because in my opinion, this might makes the situation worse. This fractional element might.
You inject. If I'm going to make surgery without any kind of laser, and you have, as you can see, activity anterior to the ridge, you can have bleeding after the surgery or during the surgery. And the bleeding during the surgery and after the surgery is catastrophic. So I could inject it, but would make the surgery 2 or 3 days later. So if you inject, you must be ready to make the surgery. In other words, I would inject just if I'm going to make the surgery, know the day of the surgery, and the baby is already booked for the surgery. Okay. If I don't have any kind of OR, and you know that in the COVID era, it's sometimes very difficult to have an OR ready and booked, we could also do laser just to hold the retina. And then, for sure, you have always to make a surgery, but it's not such a sudden surgery than if you inject. So you have those two options. And you have those two options because it's a gray area. You don't have a surgical road book, you know?
Yes.
So we do it according to the conditions we have and the baby that we have. So you have fibrosis, but you still have active disease in this case. So you could have those two options, and if you choose one, you must go to the OR. If you choose the other one, you can just postpone a little bit the OR, but it's a surgical matter.
Okay. In fact, the child was, in my opinion, it was a surgical matter, but the child was critically ill. The anesthesiologist refused to put him under. So this is focus or zoom in on the tractional detachment. So I lasered the child. This is
that's the other option. You could laser and wait. Yes.
And direct laser ophthalmoscopy was performed the same day. This is a picture with the laser, and this is a posterior pole, and this is the other eye. Okay, I waited because the child couldn't go to the OR, and this is the child 6 months with no surgery. This is the first picture with the tractional detachment, the immediate laser thereafter, and on the left-hand side, this is the picture 6 months after the child with resolution of the tractional detachment and the fibrous tissue component starting to separate from the retina. So laser still has a role, and it has to be judicious. You have to be don't overdo your laser. This traction test might increase, and should follow the child very carefully, like Dr. Susana said, because you might go to the OR at any time. Recurrence after injection. This is the issue we're talking about. When to expect the recurrence? Any difference between the anti-VEGF types and accompanying comorbidities? Does it differ when you begin to appreciate recurrence, and what to do? Dr. Mostafa, can I ask you about this? When to expect the recurrence in a child injected?
Can we just postpone discussing the recurrence because we have 2 cases of recurrence, and then we have the answers of this.
Okay, we can postpone all of this. But can I ask only about the optimum dosing? Do we all give the 50% of the dose of the adults? Have anyone adapted what we call the ultra small dose introduced by the ROP study and this study? published by Islam Shireen and myself. Dr. Hany, do you always give have the dose of the adult, or have you adapted the CARE ROP study criteria of giving less, about 20%?
I always give this half dose of adults. I never tried this ultra low dose, and over the past years, I mean, no one knows over 20 years what's going to happen, whether the anti-VEGF would have systemic effects on this child or not. But actually, until now, I have never seen a systemic side effect in any of these children. So I give this half adult dose.
Okay.
I think the idea of doses, it has to have an aim. I mean, we are giving a lower dose than adults, and we've done this in Avastin for over 10 years. And we have children 8 to 10 years old that visit us, and they don't have a problem. So why are we going for lower doses? This should be because we have some side effects of the higher dose, and so we're trying to make it less in order to have less side effects. But actually,
my question
not
have you ever seen a side effect of ranibizumab? Proven side effect systemic?
In ROP, I haven't had a side effect of the anti-VEGF. It doesn't mean it doesn't exist, but I mean, I haven't had a child who had an anti-VEGF injection that you can relate a side effect to it. Even local side effects, maybe subconjunctival hemorrhage. I mean, I don't consider this a side effect, but otherwise, we were lucky enough, and we have good experience now in 10 years. I don't feel we have the side effects that would push me to lower the dose. Exactly. Because I'm not having problems with the dose. Actually, I think the next stage would be if we have recurrences, that some would go for a bit of more doses, maybe to get past the recurrence. This can be an idea. I don't like it. I'm not pro increasing the dose, but I mean, if you don't have side effects, like in some others, some have introduced the idea of giving more of the drug. Maybe you get longer duration of action. Maybe you get in ROP cases less recurrences. But I feel that everybody feels safe with the current dose for a few years now, that they will be afraid to lower it or increase it, because lowering it can have less effect, which we don't like. Increasing it can have a side effect, which we don't meet often. So I think I'm not going to change the dose for the next 10 years for myself.
When we started using the 0.16 milligram dose, we had been using half of the adult dose, then 1/4 the adult dose, and we had a run of babies. They were very small, unhealthy babies, where I think 3 or 4 out of 12 in a row passed away. And the neonatologist started feeling that the baby's having Avastin, it was a gloomy sign, and at this point, and still the literature about systemic side effects is very divided. It's very incongruous. So we felt lowering the dose, we use 0.16 milligrams compounded in our pharmacy in 0.025 milligrams. We've been doing since 2013. And what I like about it is that you get your recurrences, and quite aside from the systemic side effects, is that we get our recurrences a few weeks earlier. So instead of 14, 16 weeks, we get the recurrence at 8 weeks when we're still watching them closely. So they're in our mind, and the recurrences don't surprise us. They come sooner. The efficacy is about 80%. And some of our babies are 5, 6, 7 years old. I can't share the data with you because we haven't fully analyzed it. But we're looking at their developmental scores. We're finding that the babies that have had no treatment have got the same developmental outcomes as the 0.16 milligram bevacizumab babies. So for sure, at that tiny dose, it doesn't seem to have any effect on the development at 2 years. But I'm skeptical about the higher dose. I just don't know. I like the lower dose.
The period of time where the anti-VEGF remains in the blood circulation. We know quite well about Avastin that it remains in the blood circulation of the neonate till 12 weeks or 13 weeks post-injection. So if you get a recurrence and you re-inject him with the same half dose of the adult, you will have a lot of anti-VEGF in the circulation. We don't know exactly what this is going to do to the child. And as for the factors that you haven't seen complications from injection, there is a lot of confounding factor about this. There is a lot of comorbidities in the child that can happen from anti-VEGF injection. For example, if simply the child has an opened ASD or a patent ducted arteriosus that is going to close. And when he injected the child, and this is a lot of children that you ask the parents about their heart condition, and you find an ASD or a patent ductus or a contraction of their pulmonary artery, you don't know if this anti-VEGF you're going to give is going to affect this closure or this heart condition, because definitely anti-VEGF has a role in the organogenesis of the heart and the brain and in the lung of the children. So the systemic side effects has not been published in the literature. We couldn't see ourselves, we couldn't put our hands exactly on the systemic side effects. This doesn't mean they don't exist. So giving half the dose of the adult is quite tested, but giving the same in a recurrence case so soon after the previous injection, I think myself is slightly risky, especially in Avastin, which crosses the blood-ocular barrier so well.
I agree that the second injection is better, a little bit lower, especially that you know that the disease is not producing a whole lot of VEGF for 10 years or so. So just, you know, a push would finish the VEGF. So I agree totally. Second injection less.
In my experience, I agree with Souka, because, well, we are so used with the dose, and I also, from my knowledge, I don't found or was reported to me any kind of problem in the development or in kind of complication from what I know with the use of anti-VEGF. And in my experience, I never had any kind of problem. So I don't think, of course, when I put timolol in my eye, I can have an asthma. So I put anti-VEGF Avastin in the eye. Of course, I will have Avastin in the blood circulation. But do you really know in children with a lot of problems how much is the normal VEGF in the circulation? Because I recurrently have this scenario is that the baby is very bad, I make the injection, and then the baby is getting so well. So we are using a drug, okay, that I have quite often this. So it's really, I think the drug goes inside the circulation and makes some effect. But if it is bad or if it is a good one, you know that intraventricular hemorrhage is like the blood in the neovessels of the brain, of the inside the brain. So perhaps this anti-VEGF, this Avastin or this anti-VEGF in circulation is not that bad as we can think it is. So of course it's there, but we are used with a dose that is comfortable to us. We never saw any kind of complications. And you know that we need 1,000 of babies to be sure that the complication that you can imagine is linked with anti-VEGF, because the problems of the babies are multifactorial. It's not just the problem of anti-VEGF. So the good that anti-VEGF makes in the eye, I think that is balancing, and it's a good way in the balance, you know, to use the anti-VEGF, although it can have these effects, and we are aware that it can have its effects. But it's so good in the eye. The child doesn't get blind, so that's a price to pay if you have some problem in the brain or some problem that you already would have, or in the heart or in the kidneys. The only restriction I make is if the baby had a problem in the bowel and has a recent surgery, I don't like to inject. I mean, if the baby had a necrosis of the bowel and he made the surgery this week, I try to postpone, because I know the drug gets inside the blood and you can have problems in the suture of the bowel, like in the adults. You just do Avastin 1 month after the surgery. So it's the only thing I balance when I know that the baby made the surgery this week and I see the baby and it's terrible in the eye. Sometimes I do laser. Or I always tell the doctors that don't suture again the bowel in the next 2 months, because I know there is Avastin inside the eye. So they postpone the surgery of the bowel for 2 months. So it's the other things, and really, it's a very good drug. And although we have these little things, I think we must go on using it. And as Souka says, I think in the future, perhaps we'll want to laser just in very gray areas or in very surgical problems, I think.
Just have one comment to add.
I think we have to move because the time is running. I just want to make one more point clear about the injection. So we have discussed the dosing. The timing of injection has to be clear. So Dr. Hany, if you got a baby that is indicated to be injected the 31st week, do you inject it because it follows the criteria of the ROP study, or do you wait till a certain point?
Well, I follow the criteria, but the criteria do not cover every single case. I mean, sometimes you have cases that do not fall out within this protocol. So I inject patients whenever I see that I have a real risk of progression, plus disease, zone 1 disease, stage 2 or 3, zone 1 or posterior zone 2. I follow these criteria, but believe me, it's not a very solid method, and I also rely on progression. If I see the baby within 2-3 days, and I see there is progression and the starting forming ridge, I go ahead with injection. Remember that sometimes when you wait and you leave a ridge to develop, it regresses after injection, but it leaves some macular dragging, for example. So I think early intervention is better, is much better in these cases.
So we can inject whenever it is indicated, regardless the gestational age, right?
Yes, yes. Because you have babies, I mean, I've injected babies even earlier than this. I had babies that were 26 weeks gestational age, and they started to develop the ROP at 30 weeks of gestation, injected them, and they had recurrences later, and re-injected them again, and they were doing fine.
Okay, Ms. Hillier?
I think you can inject at any gestational age. I think we're going back to what we discussed before, that birth weight is the main criteria.
Okay, my point is that according to this famous chart in the BTROP, that the disease has 2 phases, and in many published data that if we inject in phase 1, where the VEGF level is not that high, we may end up with a large area of chronic avascular arrest or larger area of avascular retina. So do you agree with this chart that we have to respect the gestational age and inject after the 34th week, or still you can go 31st?
No, I am aware of the chart, and I think it's very interesting in terms of understanding the pathogenesis. The way I think of it is that 34, 36 weeks is prime time for developing pathological and hitting threshold disease. So I find myself very rarely treating before that stage. But if I saw aggressive disease at any stage, post-menstrual age, I would be happy to treat at that stage. So it's a bit like the findings of WinROP. I'm aware of it. It may sway me slightly, but it doesn't overtly affect my treatment decisions, no.
Dr. Susana?
The same. So I treat in indications from the ETROP, whatever the gestational age is. So, I mean, if you have a threshold ROP or pre-threshold ROP, type 1 ROP, I will inject wherever is the gestational age, because, you know, sometimes postmenstrual age is not quite really, the mothers know really the gestational age. So I guide myself by the disease. Myself in the first observation by this criteria, the usual criteria from the American Academy. I usually like to see the babies a little before in stage 1 of the disease, just to know how far the vessels are there. So, I mean, if I see the baby at 30 weeks of postmenstrual age and still the vessels didn't came out from the zone 1 or from the macula, I know I'm going to have problems with this baby. So I will follow up this baby. Do you understand me? It's not
Yes.
really the postmenstrual age, the gestational age, but really the disease that matters to me. And unfortunately, I had to inject at 31 weeks of age, of gestational age. And of course, those babies are a little bit different. They are very difficult ROPs to treat. They have recrudescent disease that we have to treat again. And there is perhaps some kind of genetic problems if the babies have this very early and very aggressive disease. But that's another problem.
Dr. Abdel, did you interact at any age?
This is not the time of the gestational age.
Dr. Abdel,
like Dr. Roxane and Dr. Susana said, most of the time where we come to examine the children, we see the stages of the RP starting at 33 or 34 weeks. So this issue is not a big issue except in aggressive posterior RP, where we get the changes in 30 weeks or 31 weeks. In the past, I usually panicked and injected the children as soon as I saw them. But in the late years, I had 3 or 4 cases of this when I chose a child at 30 weeks when he has an aggressive posterior ROP, or at 31 weeks when he has an aggressive posterior ROP. And I waited for 1 or 2 weeks, seeing the child every 3 days. And I injected him at 33 weeks to respect the VEGF level inside the eye. I got the same result. The child didn't worsen that much in 1 or 2 weeks. Of course, you have to follow the child very carefully. If you see the child every 3 days and you find he's worsening, you have to inject immediately. But if the child is doing the same at 31, at 30 weeks, I wait till 32 and 33 weeks. You should wait till 33 weeks, but as Dr. Souka said, sometimes the postmenstrual age is not accurate, and 34 is actually 32, and the 33 is actually 31. So if I see a child with aggressive posterior ROP very early, at 30 weeks, at 29 weeks, at 30 weeks, I wait for 2 weeks when I'm seeing the child actively or closely every 3 days.
Okay. This is a case of aggressive posterior ROP that was injected 0.25 milligram ranibizumab, and during the first 2 weeks, the acute stage starting to settle down, and by the end of the first month, we ended up with this nasal fibrous band with vascular dragging and a little bit of macular ectopia, which remained stable till the end of the 6 months of follow-up. So, Dr. Susana, do you operate such cases or do you just follow up?
Well, usually those cases are progressive cases, slowly progressive. They are not very easy cases to treat because you have a tangential component of the detachment that it's very difficult to deal in the babies. So you don't have the plan of cleavage between the posterior hyaloid and the retina, and you don't have a way to peel inner limiting membrane and take all those membranes at such an early age. So I never had to do this kind of cases until now, okay? But what I feel is that you have a tangential and very difficult surgical case to deal with. From what I see,
I mean, you will follow until retinal detachment.
Perhaps you could follow, because it's nasal, you could follow it until you have a dragged retina, and perhaps you have some kind of, the retina is more mature and you can do almost an adult surgery. What happened here is that you have nasal flat vessels that contract and originate. As you can see in the first image, you have nasal flat vessels. So it's a very posterior, aggressive posterior ROP, where the nasal side is much more worse than the temporal side. So the problem is in the nasal side. And the nasal side was dragged by this tangential force to the remnants of the posterior hyaloid artery that is inside the optic disc. So all the nasal side is dragged to the optic disc. I as I'm telling you, I never had to do this kind of surgery, only once, and I'll show you the result if you have time. But if you have the retina, if you have the macula not tracked or detached, I would wait. I would really wait. And but in any time of this timeline, the children may need the surgery. I don't have really experience in this kind of surgery, as I told you, but with tangential forces, it's very difficult to make the surgery in a very, very, very young baby. So I had the experience of peeling membranes and inner limiting membrane after 8 months of age. 6 months, still very early. But it's a slower, from what I see, it's a very slower progressive disease. With the macula on, I still would wait.
Actually, I followed this baby till the age of 3 years, and it's the same fundus image and same fundus appearance without any progression of this traction.
Yes, it's a traction from the nasal side, from the flat neovessels, tangential to the hyaloid artery, so the reminiscence of this embryonic vitreous. I think it would better.
Dr. Hany, do you operate or just observe?
I think in such a case, I would just observe the patient. Surgery will not unfold this retinal fold that may even lead to complications. If it is stationary, as you said, I would just follow up the case. Probably the disease has regressed and stayed as it is. If it is progressing, then I am forced to intervene. But I think it's a very wise decision to wait.
Dr. Abdel Hadi?
The same case?
Yes, the one with this.
Can I get the picture, please? When I get this child with aggressive posterior ROP and I injected him, and I see him after 2 weeks with this, I would go on in surgery after 2 weeks with this tractional fold starting, because I don't know where it will end. It will end in a nasal ROP or a full traction detachment. And aggressive posterior ROP are serious conditions and they need aggressive treatment. But if the child presents to me at 6 months with this picture, I would agree with Dr. Hany. I would follow up the child. I have a lot of children with this nasal forces, and I've done handheld OCT for them, and they are fine for a long time. But you never know when the aggressive ROP will end into this 6 months picture. If I get the aggressive ROP starting to recur or starting not to quiet, is not going into quiescence, like the picture in 2 weeks, at 2 weeks I would intervene.
Okay. Dr. Souka, would you intervene at 2 weeks?
No.
Okay.
I don't know if it will be a favorable outcome, but I still feel that surgery in ROP is the last option for me. I would wait as long as the macula is still on. Patient would be in the area of 660 at worst. I mean, no, only when I'm threatened that it will be really a bad outcome, I'd like to do surgery. I'm conservative in ROPs.
This is a case that was stage 3, zone 2 plus 2 days after injection, and 2 weeks after treatment, the vessels disappeared with a residual ridge seen inferiorly. By the 5th week, we have this recurrence of new vessels at the initial site of the ridge. Ms. Hillier, would you treat or observe, and how would you proceed?
So let's see, 5 weeks. So that's not lifted retina. That's just recurrence of stage 2-3 disease, right? From what I can see. And I mean, this looks to be a little bit further out than the original disease.
Yes.
Yeah. I mean, I'm not averse. It's well into zone 2 now. I can't tell from the picture, but am I right to say that?
Yes, it's zone 2 recurrence of just new vessels again at the initial ridge.
Yeah. This is at the initial ridge. It hasn't extended at all, huh?
No.
No. Yeah. I think It's a tough one. It's still pretty posterior, and if it's still at the initial ridge, I think I would probably give some more Avastin in this situation. I think if the vessels had gone out a little bit further, I would have no hesitation in applying laser. I would say of 10 babies I treat with Avastin, 2 will have a recurrence at the low dose we use. I would say of those 2, 1 would have further Avastin and 1 would have laser. That's roughly my odds. Probably this baby, because the disease is still quite posterior, I'd be inclined to give a further dose of Avastin to 1 or both eyes, depending on what was, which was affected.
But you will treat, right?
Yeah, I would, because recurrence is a very real thing, and I think there's multiple criteria to define what is recurrence after Avastin injection. Recurrence of plus and recurrence of neovascular activity to me are quite easy to quantify, quite definite endpoints, which would trigger further treatment as far as I'm concerned. Yeah.
So Susana, would you treat?
Yes, definitely. If it is a recurrent disease, I would treat. In this case, as it's not yet surely in zone 2, I would give again an injection. But most important in this case is if you have the diagnosis of a recurrent disease, you must treat. You cannot wait. You cannot wait to treat an aggressive posterior ROP. If it is really an aggressive posterior ROP, you must treat. In this case, if you have again plus disease, again you have these 3 diseases, as I can see, I would treat the baby, most probably with injection, because I think it's still in posterior zone 2. So I agree.
And there is no way for spontaneous resolution, right?
Well, I never saw if it is really relapse disease. If you have plus disease and proliferation, I wouldn't bet, just very luckily or anecdotally, it would disappear. Now, if you have just an active area without plus disease, I will wait. And sometimes I've got this, it seems like a 2 disease, but it's not. It doesn't stop to be a 2 disease, and then the vessels grow to the periphery with this kind of 2 disease, and they grow to the periphery. But I don't have a plus disease. In that case, I really observe just the baby and follow up the baby. Sometimes, and even more, I do angiography, fluorescein angiography, just to see what kind of activity is in the periphery. But if it has plus disease and recurrence, and again, stage 3, I would treat. I would not wait.
Dr. Hany, would you treat?
Well, yes. I think once you have this diagnosis of recurrence, you go for treatment as early as possible. And the more you wait and observe, the more the chance of this recurrence developing more fibrous tissue. It's a fibrovascular component, so the fibrous component will become more prominent. And then when you decide to treat, you get this crunch syndrome or traction on the peripheral retina. Here I would go for a second injection, and even if this recurrence is a little bit more peripheral than the original ridge, then I would go for an injection as well. And he has a very good chance of resolution and leaving the laser for a last recurrence. Remember that injections are also life-saving in critically ill infants, because it's much easier to do than the laser. The laser, you need a long time. You have to put him under anesthesia. So even if this child is critically ill, injection would be life-saving for him.
Dr. Abdel.
To start with, this is stage 3, zone 2, right? Disease,
plus, yeah.
Yes, and I can see a plus because around.
No, this is 2 days after injection, and
this is 2 days.
Yeah, 2 days after injection. Yeah.
Okay. So I can see the recurrence vessels. The picture is not a good quality vessel. I could quality picture. I would take your word that there is new vessels at the ridge. What is the post-menstrual age of this child at 5 weeks? This child is, how old is the post-menstrual age?
39.
39. And he's there is a plus disease with it, because you can't see the disc under central.
No, just the new vessels starting again at the initial reach.
I would follow him in another week. I would wait for 1 week and then decide.
Dr. Souka?
Yes. Well, I think the issue here is simple. If you know this is a recurrence, you see the new vessels, definitely plus sign means VEGF is high, I would inject. If you don't have a plus sign, then you have to evaluate the condition, and it will depend on how can you follow this patient, if he can come back or not. If you feel he is leaving now and you're not going to see him in 2 or 3 weeks, I'm going to inject. If you can see him a bit often, I might observe for 2 or 3 weeks, because it's not so aggressive in my opinion.
Yes. So we followed this protocol of follow-up, and after 3 weeks only, this new vessel has disappeared, and with good peripheral vascularization, even extending up to between zone 2 and zone 3.
Yeah.
And me and the baby were lucky, yes.
No, but you didn't have plus disease.
Yes, sure.
Yes.
You didn't have plus disease in that case. So
Yep.
I thought you had plus disease and stage
No.
2.
So did I.
Plus means
without
VEGF
plus
is
is
high.
Just the new
Correct.
vessels.
Do you understand me? So without plus, it won't get better. If you have
Yes.
plus and this, you could inject. Without plus, you follow, of course, because it's not a relapse disease. And they did well. You did follow it, and it went well.
Yeah, I agree with Dr. Abdel Hadi that a lower dose in the second recurrence is definitely justified. I would go for the least drop of anti-VEGF in the eye with the second injection.
I think this is the issue Dr. Abdel Hadi was discussing, the risk factor for recurrence. And according to literature, it's low birth weight, extent of pre-retinal neovascularization, and this is known from the ROP, the threshold disease, definitely the aggressive posterior ROP, pre-retinal hemorrhages, the duration of oxygen, especially after intravitreal injection, and injection at low gestational age was reported to be one of the risk factors for recurrences.
There are other factors for risk factors for recurrence. Ellen Mintz-Hittner has a very interesting paper about her risk factors for recurrence. And one risk factor is the velocity of growth of the normal vessels. If the normal vessels grow very slowly, you know that most probably you'll have a recurrence. I mean, I inject 5 weeks later, the normal vessels, the vascularization of the retina is in the same place. And 8 weeks, it's just a little more, but almost in the same place. So the speed of growing the normal vessels is also a risk factor for recurrence. So when I inject a baby and see the baby 4 weeks, 6 weeks later, and the vessels, of course, the disease disappeared, but the normal vascularization is in the same place. It's a very risky for recurrence, and it's not there on that list. It's a very interesting paper of Ellen Mintz-Hittner. You can find it. It is a sequela from the HOPE ROP.
Okay.
Would I make myself explain?
Yeah, it's understood.
Yes.
But I think it would need very, very meticulous photography, and comparing the growth of the vessels, and I'd go for fluorescein at that point, to compare vascular growth and revascularization of an area.
You can see it. 2 weeks,
Okay.
3 weeks, 4 weeks is in the same place. Be aware.
Okay, this is the last case. This is a child that was presented with very narrow pupil due to dense tonic vasculosa, poor dilatation, and barely seen by the indirect that the vessel ending between zone 1 and zone 2 was plus disease. And at this point, do you treat, or how would you proceed with this rigid pupil, Dr. Susana?
Well, really, it has not completely.
I know it. It's
a
not
plus
obvious for
disease.
you.
It's not a plus disease completely. So you have a rigid pupil that it's not a good sign, but it's not a plus sign. So you may have persistence of the tunica vasculosa that is not a plus sign, but tells you that you have a lot of VEGF inside the eye. I cannot tell you, just can tell you that it has not a plus disease, so I'm not completely sure.
The vessels were thick, and tortuous
I
and
would
not so
ask
good.
the baby to come and to see the baby. I had to see with indirect ophthalmoscope to see really what this means. But it has some criteria of very bad disease. So tunica vasculosa lentis, rigidity, perhaps you have an aggressive posterior ROP of this in the inside the eye. But just with this image, I'm not completely sure what to do. Perhaps we should inject, because laser you cannot do for sure. If the baby had some kind of aggressive posterior disease, what is the most probable I would inject? But I must see the baby.
Okay, Dr. Hany?
Well, I agree that, if ophthalmoscopically I can verify there is a reasonable amount of suspicion that this baby has aggressive posterior ROP, I would go for injection. If I cannot verify that and I can see the fundus ophthalmoscopically, then I would wait for 2-3 days, re-examine the baby, see how the dilatation would go. And if things are going worse, I would inject. If he's getting better and I can verify his condition more, then I would wait for him.
This baby was injected and dilatation was much better 2 days later, showing this picture. And we just follow up the patient till the end of the 6 months, showing this poor peripheral vascularization. So I just kept following up the patient, and by the 8th month, I have this vitreous haze with very poor peripheral evaluation for peripheral vascularization. So do we have any additional tool to evaluate this condition? Is it progressing? Is it recurrence? Because this vitreous condensation after injection sometimes occur due to resolution of the ridge. So, Dr. Abdel Hadi, would you recommend any further investigation?
How old is this child now? 6 months?
8 months. 8 months. This is 8 months.
And he's doing well systemically and everything, and the pupil dilated well, no plus sign. Of course, if you ask for an FA, you could find the peripheral ischemia, but I wouldn't ask for an FA. I would follow up the child. It's difficult to not to be able to comment on the retina even through this vitreous condensation. Of course, FA will solve your problem, but what will it add in the treatment? Will you inject this child? Would you laser the child even with
if you find that there is large area of about at the age of 8 months, still there is a large area of avascular retina, would you wait? Would you laser? Would you treat?
We were discussing, this is still a gray zone. Half of these children I usually follow up, and half of the children I laser. But I'm tilted for laser if the child is going to be lost for follow-up or going to travel to another country. I'm tilted to follow up without any laser. If the child began to develop myopia already, the laser would make myopia worse. Peripheral avascular area with color photography with no vessels. I know the fluorescein was going to show this very well, even with a condensed vitreous in front of it, but I don't think the fluorescein will add to my decision whether to laser or not, or to follow up.
We did laser. We did the fluorescein just to ensure what we have inside this eye. Dr. Susana, would you treat or just observe in this large
I would observe. You don't have activity in the periphery. It's not a very late angiogram, but you don't have really any kind of activity, neovascular activity. You just have the vessels stop there. So usually in these cases, I follow up if I can. I like to follow up these vessels just to know how they are going on to the periphery. And in this case, I would not do the laser. If I could, I would follow up. But if I cannot have the baby with me, if the parents cannot bring me, if I've somehow cannot reach again the baby, of course, I could do some kind of the laser of the periphery, because it's already a very intermediate, almost peripheral zone 2. So it won't induce any kind of myopia nor any kind of problem with inducing of a refractive error. But I don't see any kind of activity, just closed vessels, so they don't go to, didn't go to the periphery, didn't grow through the periphery.
And how frequent would you follow up?
Yes, of course, I would follow up.
Frequency?
Yes.
How frequent?
Every month, every week?
No, this baby is 8 months of age, is that?
Yep.
Yes.
Usually I follow them each month.
Each month. Okay. Ms. Hillier?
Yes, something similar. I think we did the angiogram to ascertain whether there was activity or not, and there isn't, which we would have expected. Vessels are lovely and slim, so I would observe that every 1 to 2 months, I think, probably feels about right. Yeah.
I don't think that peripheral ischemia is a problem. I feel only if you have the response, if you have new vessels, if you have something like tortuous again vessels in the posterior pole, then you'd be, trying to lower your VEGF. But just having a peripheral avascular area, I feel just going to grow with time. Keep an eye on it. That's it. That's my feeling and how I manage them, actually.
And that's why I like to, in these cases, I do always angiography, just to learn and to know how it works. Sometimes my problem is not this case. Is like this, and then you have one
tiny one,
a little bit of neovessels. You don't look, you cannot see them in the ophthalmoscopy, so they are quiescent, or they are remnants of neovessels. But if you make the angiography, you see them. So that's my problem. Do I follow up them? Because they are regressed neovessels. I don't do it in diabetic retinopathy.
Yeah.
Make
and
if
you find this,
that's my problem.
Yes, if you find this pinpoint leakage, don't you think of the new term, the ROP, which is a combination of the familial exudative disease with ROP?
Yes, it's ROP. Yes.
Would you think of that, right?
That's a little bit different. You always have some kind of activity. Always. You between at the end of the vessels, you have loops, and those loops are not normal. They always have fluorescence, they always die. The dye gets outside. You don't have really a proliferative disease, but it's not quiet. And those cases are the cases where the normal vessels really don't grow. I mean, they are 4 weeks in the same place, then they grow a little bit, another 4 weeks in the same place, and then you have a relapse disease, and then you inject, and then you at 1 year of age you still have this. I'm not sure, but I think those babies have a mix of fever and ROP,
Yeah.
And those babies
has to go for laser, definitely.
Yes, those are the babies that are laser. Those are the babies that I don't have any. If I begin to feel this, and it's just a feeling because you don't have real criteria, those are the babies like this one on the first on the top on the right.
Right, so
the laser, the laser does,
Great.
Because I don't feel comfortable, and I had a case of this that ended terribly badly, and I think it was a ROP, so it was a fever in a baby, premature baby.
That's one indication for laser for me, yeah, definitely.
Yes.
So I think now we should move to Dr. Teixeira's presentation about vitrectomy.
Oh my God. But my presentation, well, it's a big one.
Big one. Ah.
Yes, it was some kind of what can I say, a lecture. So this is a little bit more dynamic than just like. So it's not a surgical. How can I say? It's not surgical cases. It was just some tips about the vitrectomy in ROP, and it's just to share my experience. That it's not a huge one experience, but it's humble. I'm trying to share my doubts and what I think about the vitrectomy in ROP, and that's how I feel when
most of our audience are not really, vitreoretinal surgeons that intend to go for ROP surgeries. So I'd go for, something for people who do not really operate on these cases, like when to do this, send them, and, your advice to them, because the viewers are not really going for the surgery.
Let me just go to the first one, because I'm not in the first one. So, the problem with vitrectomy in ROP, it's nothing in the vitrectomy of the adults prepares you to the vitrectomy in the children, because it's a unique challenge. The eye is completely different. It's very stressful emotionally, because all the OR is very tense around this little thing, the baby. It's very technically demanding, and you must control yourself and try to, when you have a vitrectomy for ROP, you must be quite calm and have no more schedule in the OR. That's my advice. So there are a few questions or a few topics that I'm going to speak about. And first is, how different is the premature eye baby? So the main difference between the baby and the adults is that we have a shallower anterior camera. It's a very, very little eye, but you have a huge, thicker lens. So when you go and look at the eye of the baby, you have this, the blepharostatus, and then you just almost have cornea. And the big problem is, where do you perform your sclerotomies? So there is a lot of ways and algorithms that tell you where to perform those sclerotomies. In the first one, in the postmortem, this one in the live children, but it's very difficult to do it. So I usually use transillumination of the pars plana to know where the pars plana is. I measure it. I take a little bit less, 0.5 less than what I measured, and then I get inside the eye. So, as you can see, a little bit less than the distance from the limbus to the pars plana, so a little 0.5, and I go inside the eye. So more than algorithms, I try to see exactly with this transillumination what I get inside the eye. So it's not very difficult, very easy. I tell you, the first thing that is to put the trocars. And then we must move the position of the trocars according to the placement, to the retina, where the retina is displaced anteriorly. And in this case, all my trocars were in the temporal side, because all the rest of the retina was dragged anteriorly. So it's very difficult to get inside the eye. The trocars are huge. So if you put all the trocar inside the eye, you see it's very huge, that needle. So I just put half of the needle and then slip to get the trocar inside the eye, in order to not to have all the needle inside the eye. And usually the trocar is perpendicular. Now you have all the kind of ways to get inside the eye, with trocar, without trocar, because some eyes are so tiny that you cannot get inside the eye with a trocar, just with the vitrectomies. Then you are inside the eye, and now inside the eye you have a unique retinal detachment. The retinal detachment of ROP is mainly and only tractional. You have different stages, stage 4A with the macula attached, 4B with the macula detached, and 5. And the progression from stage 4 to stage 5 may be terrible. So it's a dynamic, it's a dynamical tractional detachment, not usual in the adults, even with the diabetic retinopathy. So this is an eye, the temporal side, the nasal side, and this is the temporal side. And I pretended to make surgery to this eye. The baby gets very sick. I could not make the vitrectomy that week. So I postponed 15 days this vitrectomy. And 15 days later, I already had a retrolenticular proliferation of, as you can see, of the retina. So it's a very, sometimes it's a very dynamic and progressive detachment. Inside the eye, you don't have the vitreous gel of an adult. No, you have a very thick gel with remnants of embryonic structures. So it's completely different from the adults. And you have something like neovasals, flat neovasals, and you have no anatomical plan between the retina and the vitreous. So forget to do posterior vitreous detachment as we do in the adults, or to peel the inner limiting membrane of a baby of 34 or 38 weeks of age. So it was impossible. Inside the eye, there are completely different from adults traction forces that we must really know when we address this kind of retinal detachment. And this is the main or the most important thing that we must know when you go to make a vitrectomy in ROP. So we have anterior posterior tractions, and it's not just like in adults, the flap is coming anteriorly. No, you have tractions, vector tractions from the ridge to the posterior lens of the posterior surface of the lens, to the pars plana, to the base of the vitreous, and to the optic discs, all remnants of the primary vitreous. Then you have centripetal forces. What are those? Are forces that pull the retina towards what was here. It was the remnant of Cloquet channel, and simultaneously the contraction of the fibrosis of the ridge also is part of those centripetal forces. Finally, what happened in that eye that you saw all the retina from the nasal side dragged to the temporal side are those tangential forces. So those tangential forces are the forces usually they are made from the contraction of these flat neovasals that pull the retina, slip the retina to the optic disc where there was the hyaloid artery. So when you get inside the eye, you must read the retinal detachment and know what's happening. These are the centripetal forces that pull the retina to the center. As you can see here, I'm trying to, now those are the anterior posterior forces that I'm cutting. So we must address all the forces that are pulling the retina. So we must read this retinal detachment and just cut those vectors, those vectors of those vectors of forces. So I'm cutting here the centripetal forces that link this to the optic disc. So the most important is that when you get inside the eye, you must know those vectors and read the retinal detachment when you get inside the eye. So this is that retinal detachment. As you can see, it's a very hard stage 3. I injected and did the vitrectomy, and I just cut it. The tractional forces didn't peel, didn't do anything, and then the retina slowly calmly go to its place, and the retinal detachment disappears. That's a aggressive posterior ROP, as you can see here, vitrectomy. So it's just a mushroom of membranes, as you can see here, the retina bent over the optic disc. So it's a mushroom of retina and membranes, and it's almost impossible to make this surgery. That's why I told you not to touch that the retinal detachment from the nasal side. So in these cases, I usually do it by two surgeries. I mean, the first surgery, I try to release all the anterior posterior forces, and in the second surgery, I address the tangential forces when the baby has grown a little bit more. So the goal of the surgery is only release tractions of the retina, okay? And it's a do not surgery. What do I mean? It's a surgery where you cannot do a tear in the retina, so it's deathly to do a tear in the retina, so it's over this retinal surgery. So do not tear the retina. Less is better than do a complete vitrectomy. So just cut the vector forces that are linked with that surgery. Do not touch the lens. So we don't want to have a cataract in those babies because it leads to amblyopia. And do not touch the vessels, because if you have an hemorrhage at the end of the surgery, it's also a very difficult picture to solve. And most important, if you are going to do this surgery, always look to the retina of the baby the day before the surgery. But as it's a very dynamic retinal detachment, suddenly you can see the retina here, but 2 days later the retina is touching, like a fold touching the lens. So always see the retina before the surgery. And there is a lot of have some kind of still don't know when to perform the surgery. I mean, the better results are in stage 4A, but you also can do the surgery in still stage 4B, although the visual results are better in stage 4A. You can also perform surgery in stage 5, but very late stage 5 with a closed funnel, the results are very limited. And open funnels, sometimes you have light perception, what is very good for maintaining the circadian rhythm of the baby. So I don't intend to flat all the retina, but at least some part of the retina shall have some kind of function that maintain the circadian rhythm of the baby. But the best visual and anatomical results are in stage 4A. What about another issue that also has polemics? Do immediate or sequential bilateral surgery? I mean, do you do this if the baby has stage 4 in both eyes and needs surgery? Do you make the surgery at the same day in both eyes, or you postpone one of the eyes? Well, this has a lot of polemics, still has pros, has cons, but I feel that it's much better to the baby to make the surgery in the same eye, both in the same day, both eyes, although we have a lot of cons. Do we spare the lens, or do we do a primary lensectomy? And that depends on the distance of the proliferation to the lens. So if I have space to do a lens spare vitrectomy, I always like to do a lens spare vitrectomy. But if I cannot, I sacrifice really the lens and have no problem to sacrifice the lens. Again, posterior vitreous detachment and inner limiting membrane, they don't exist, at least in my hands, until 8 months of age. And in 8 months of age, we can have a plan of cleavage between the posterior hyaloid and, as you can see here, detach gently and do some kind of technique very similar to the retinal detachment in adults. So at 8 months, you can already induce a posterior vitreal detachment. Finally, shall we use anti-VEGF before surgery? Sometimes other colleagues also use after surgery. Also here, it has pros and cons. in my hand, I think that it facilitates the use of anti-VEGF pre-surgery, facilitates very much the surgery because they avoid very much the hemorrhage. The only problem is if I inject a baby and suddenly the baby is very sick and I cannot make the surgery 2 days later, and I just do the surgery 2 weeks later, and that's a big problem because in this kind of retinal detachment, you have a total retinal detachment with stiff membranes, very difficult to make the surgery. So in these cases, I usually inject the day before, not very many days before, because those babies can really have this kind of problem. Finally, do we suture or don't we suture the sclerotomies? I usually suture the sclerotomies, although I use 27 gauge. But I'm very afraid of endophthalmitis and depotonus with hemorrhages. So I usually suture sclerotomies. Well, so vitrectomy is a unique challenge, as I used to say. It's a very stressful but wonderful surgery. The microincision allow us a safer and better surgery. And we have, making the surgery earlier, we have each time better and functional anatomic results. So in my hands, treating ROP and making vitrectomy is a mission and is a passion. So that was what I, so it's not, it was not clinical cases, but the experience or the doubts that we can have when we are doing surgeries. Is that okay?
I think it was very comprehensive and nice tips for people who would like to have an idea about the issue. I'd like to hear comments from our panelists on the topic, of going to surgery. Minor advice, let's say, for people who would like to try ROP vitrectomy surgery. And I'll finalize this webinar at the end of your comments. We'll start with Dr. Hany. Muted, Dr. Hany is muted. You'll have to repeat after me.
It's a very nice talk, Susana, and very nice tips you have enlisted. I stopped doing stage 5 ROP. I have to say that because of the poor visual results and the high expectations from parents. I operate on stage 4A and cases in which the macula is threatened. But cases with a fixed macular fold, even 4B that is stable over time, I do not operate them anymore. I agree with you that there is no role for posterior vitreous. You only have to imagine the forces acting on the retina and cut these vitreous fibrils that exert distraction, and the retina will settle in the post-operative period. It's a very tough surgery, as you have said, and very demanding both for your coronaries and for your as well.
Roxane Hillier.
So, thank you. It was a fantastic presentation, Susana. I must admit, we have not had a retinal detachment of any sort in our region for 12 years. And in the UK, there's just a handful of cases per year. So in the last 5 years, surgical care of ROP has been centralised to 2 units, centralised around Great Ormond Street in London. So actually, my contemporary experience with vitrectomy in ROP is very small. I aim to try and stop the detachment happening.
That's a good job, because you just do vitrectomy because something wrong was very wrongly done, Yeah. So vitrectomy to me is a failure. So if I go to a vitrectomy, it's because everything else failed. And that's not good. So I think you do a good job, and I don't vitrectomize my babies,
No.
You must do the job to avoid vitrectomy. Really, it's the last thing I want to do.
I think if all our efforts is trying to avoid the surgery, results will be much, much better in ROP in general, So, Dr. Ahmed Abdel, you have something to add? The surgical options?
Very nice presentation, Dr. Susana. I learned a lot. it's a very challenging specialty. We need a lot of doctors, like young doctors, promising like Dr. Mostafa, to raise and to have a more efficient screening program. A more efficient screening program will stop surgical cases from appearing, and they are definitely decreasing in the last years. Challenging situation, challenging surgeries, zero-error surgeries, like Dr. Suzanne said. Breaks are not always forgiving, or are rarely forgiving. So my advice to master the techniques of examination, to care for the children a lot, to see them, to know when to inject and when to do laser, and to hopefully prevent the appearance or to have any stage 4 or stage 5 in the future. Again, very nice talk, Susanna. I learned a lot from you.
Thank you.
Thank you. So, Mostafa, would like to add something?
I would like to thank all the panel for their time and their experience. And I think it's a teamwork between us and the neonatologist, and we have to increase the awareness about the disease in all the countries, because as we started our presentation, there's still some countries don't have a clear incidence of the disease because of poor screening and poor communication between neonatal ICUs and ophthalmologists. So thank you for your time, experience, and for upcoming another discussions about ROP.
Thank you. It was really nice having you all here. It's always a pleasure to have such eminent guests with vast experience in the field. I hope we've added a lot to the ROP practice. And I hope everybody would really advise neonatologists when to seek our help in this area. And I do agree with the surgical options. It's a very last resort. I did stop doing stage 5. I don't feel it's worth the effort and time and money, let's say. I was really, I benefited a lot from this webinar. I hope everybody else enjoyed it in the same manner. And this is our last episode of the first season of iHub in iCare Academy. And it's definitely a good choice of panelists to end the season. Thank you all, and hope to have you in another webinar soon. Thanks a lot, and goodbye.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you. Bye-bye.
Thanks. Bye.